Hello, and thank you for joining ELSO's webinar series on COVID-19. Today's focus is why data matters. For over 30 years, ELSO's core mission has been focused on innovation, expertise, clinical support, and community. The organization's dedication to the development and education of novel therapies for support of failing organ systems has been centered around building data to support clinical research. With nearly 6.9 million people affected worldwide, ensuring there is sound data and science to help guide our global response to this virus continues to be vitally important. A few housekeeping items before we begin. Today's webinar is being broadcasted live on our ELSO YouTube channel. If at any point you experience any difficulties with the Zoom platform, please go ahead and log on to our YouTube channel. At the conclusion of today's webinar, the recording of this broadcast will also be available to view on demand on that YouTube channel. At the conclusion of all presentations, we will be opening for live Q&A. Please submit your questions via the Q&A tab at the bottom of your Zoom screen. Some of the questions may be answered live during the webinar. I would like to start off by introducing our first of two moderators today. Dr. Matt Paden is Associate Professor of the Division of Critical Care at Emory University, Children's Healthcare of Atlanta. He's the Medical Director of the Pediatric ECMO and Advanced Technologies Program, and he's currently serving as President-elect of ELSO and had previously served as co-chair of the ELSO Registry. Welcome and thanks for joining us this morning, Matt.
Thank you very much, Elizabeth. I appreciate the opportunity to be here and to talk about all of the wonderful things that ELSO has been doing regarding this COVID pandemic that we're in right now, and talk about how ELSO has really been at the forefront of driving the data that we need to provide the best care to all of our patients. And so we put together today an excellent group of folks from around the world to talk about how ELSO as a whole has responded and how our member chapters have been a key part of this. So I'll be helping moderate this discussion today, along with my co-moderator, who probably needs no introduction, Bob Bartlett, who is here with me. As many of you all know, Bob is a professor emeritus of surgery at University of Michigan, is generally regarded as the father of ECMO. Bob, you want to give a few statements before we get started?
Thank you, Matt, and thank you, Elizabeth, for organizing this webinar. I think you'll all find it's a marvelous program and will help us all get updated on this unique virus and this particular time in our professional lives. The registry has played a very important role in this because it's been uniquely modified by Ryan and Peter and others to help us get a handle on ECMO use in COVID right from the beginning. So with that, I will introduce Ryan Barbero, who is a pediatric intensivist, chairman of the Registry Committee for ELSO. Ryan?
Thank you, Dr. Bartlett, for that generous introduction. And I will go ahead and share our screen right now. And I think Matt Paden is gonna kick us off with the starting of our presentation, which is Data Matters, the ELSO Registry.
Perfect. And so they asked Ryan and I to talk about the ELSO Registry and the kind of role that it's played both in COVID, but in addition to just how we collect data on all of our normal patients. If you want to go to the next slide. So disclosures wise, Ryan is on a K-12 right now and is the current ELSO registry chair, and I'll be taking over as president in September. Next slide. So as Bob just mentioned, at ELSO, we really have always known that data matters. And so for those of you all who have not seen this picture before, this is the picture from the first ELSO meeting back in 1989 with all of the folks who came to the meeting gathered out in front of Rackham Auditorium at the University of Michigan. And one of the key things that Bob, John Tomazian, and many others did back at that time was really to put in place the foundation from the very beginning of saying, we have to have a registry of these patients. We need to know and collect data on all of them so that we can learn what the best outcomes or how to achieve the best outcomes for our patients. Next slide. So now the ELSO registry obviously has been going on for many, many years, and we don't have all the time today to talk about all of the wonderful things that it's done, but I would point you guys to this paper that Vivian, Ryan, and many of our colleagues have put together, talking about all of the wonderful things that have come out of the ELSO registry and how that registry has really driven forward ECMO care around the world. But what I do want to talk about today is kind of a tale of two times and looking at the last decade, starting in 2010 and comparing it to where we are now in 2020. So I choose this for a couple of reasons. One is 2010 was essentially right around the outbreak of the first pandemic we saw in the H1N1 disease, in comparing to where we are now with COVID. And ELSO and the ELSO registry are in very different places in both of those times. So you see here the two pictures of the front page of the ELSO registry report, first one from 2010, then this one from 2020. And the first thing that jumps out at you is total number of cases that are highlighted in red down there. So 40,000 cases in 2010. We've now tripled that to about 130,000 cases in 2020. And so during this decade, we have had tremendous growth in ECMO. And the other thing that's very evident by that, again, is looking at where this growth has been. And so if you look at the adult respiratory cases in 2010, you've got roughly 2,000, whereas we're up to almost 25,000 in 2020. And so a huge jump in the amount of adult ECMO that we're doing, both respiratory and cardiac. Next slide. So if we go back to 2010 and think about it, I actually went back and pulled some slides from talks that were given around that time and when we were right in the middle of this H1N1 pandemic. And you'll see some things that are very similar to what we've seen with COVID. And so in both cases, this disease was identified over in the Asia Pacific region. We started with these huge estimates of how we were going to be overwhelmed by this. The estimates, and this again is from a slide from the time, was that we were going to have over 330,000 episodes of mechanical ventilation in the US. Those numbers there were the US capability at the time. And so again, this real concern that we were going to be overwhelmed. Then when we looked at the actual data that came out of Australia, you saw a much more limited amount of mechanical ventilation. And you had, again, very high predictions of ECMO use in Australia. But if you go to the next slide, we see that when our Australian and New Zealand colleagues actually looked at what happened and published that data in JAMA, you really had a very limited amount. There were about 70 cases of ECMO that we already saw. But in both cases, with H1N1 and with COVID, the folks who have been to the west of where these two diseases started benefited from this, and so benefited from the experience of our Asia Pacific colleagues. Next slide. So ELSO had a response to this, and we tried to be able to help coordinate data capture during that time. And again, this is a slide from that era, and you see we tried to do similar things to what we've done this time, create a bed board. And this is the slide that documents what we were able to do during that time. And so as you see, you've got a bed board there that is not very filled out compared to centers that we had amongst the US. And the other thing that's strikingly obvious about this is the only thing that is shown on this slide is the US. And at that time, ELSO was not as, is represented globally and weren't making those efforts to reach out. The other thing was that we were a bit, at the time, a bit simplistic in the way that we did it. We had a very short form ELSO registry addendum. This was often filled out by hand at the time, faxed to University of Michigan, some were emailed in. But we did it, and we were able to capture some data on H1N1. The reporting on it, however, was much delayed. And if you go to the next slide, basically to get the reporting of this, you had to wait till the next meeting. And so at the time, the next meeting that was after H1N1 in the United States ended up being the Keystone meeting. And you see the data up there that Pauline, Bob, and her colleagues were able to put together for H1N1. And so that's what we were able to do with the first pandemic that we went through. And Ryan, if you go to the next slide, we find ourselves here now 10 years later. I'm going to turn it over to Ryan now to let him talk about the amazing work that he and his colleagues, Rob Heislop, JJ Fanning, Michelle Hurd, Steve Heyer, and of course Peter Reiches have done in putting the ELSO registry together and making it ready for this latest COVID pandemic. Ryan?
Thanks, Matt. Yeah, so, as Matt spoke to, the ELSO registry and ELSO as a community has had a long-standing history of understanding that data matters. But when we were presented with COVID-19, we recognized that we entered a world where we had the capacity to maybe approach it differently, but also a world that was uncertain, and we recognized had a dynamic understanding, which has proven to be even more true as time has evolved since then. And so at the urging of the ELSO leadership, the ELSO registry put together the ELSO COVID-19 addendum form, which is fully entered on an electronic data entry platform with at the point of entry data quality checks. But most importantly, as Matt kind of was setting up the whole time, provided us an opportunity to really do things differently, which is to, in real time, report the data. But the only reason we were able to do that is because of the engaged community of ELSO centers that changed their workflow and started reporting the data in real time. As we started to launch this platform, Peter received a lot of emails saying, hey, how should I do this? These patients aren't actually fully done. We can't fully submit them. And we said, no, we'd like you to enter it as it exists right now so that we, as an entire international community of ELSO member centers, can learn from your experience. And you've done that. And at present, this data that's here that I captured last night is already out of date because you continue to enter this data as it comes in. But it is also much, much more international, as Matt spoke to. And in fact, there are over 175 centers who have been able to enter into the real-time reporting platform our data from more than 1,000 case experiences, and from centers across all of our ELSO chapters. But it's more than just ELSO registry. It's also leaders within our ELSO community doing projects that are integrated within our ELSO community but expand beyond it. And I won't speak to this now because Dr. Lorusso and Dr. Fraser will speak to two examples of that in terms of the EuroELSO reporting as well as the Critical Care Consortium on COVID-19. But before I move forward, I do want to say just thank you. Thank you to all of you for making this possible, for making us have the opportunity to learn from your experience and hopefully to provide better care in real time to our patients and to think carefully about the decisions that we're making because of your data. But data we've also known has always mattered beyond COVID-19, and Matt spoke to some of the historical examples, but even now there are still other patients that continue to need our ECMO support while we're all busy and all working in different time zones as an international organization. And so in order to try to help us to respond to you in real time in other ways as well, this is meant to do some of the work that Peter Reiches has constantly been doing as a part of the ELSO registry since he's been there, which is answer the questions that you have. And so this is the outcome reporter on the ELSO registry platform, which if you just go up to the top there where it says the list of ICD-10 codes or a list of ICD-9 and free text in anything, you can get the associated codes, click on those codes. They'll populate down and then hit filter, and it'll give you an understanding really at a glance of their survival and run lengths and things that are commonly asked. But obviously this is pretty superficial. We also wanted to give centers an opportunity to delve a little deeper into what they're doing at their own centers. And so this is our quality reporting platform, which we're able to bring to you through a partnership with Arbormetrics. And here you see mortality by patient cohort, and here a subpopulation of just those that are children on respiratory support is being highlighted. And so it's showing here in the kind of top left corner what their mortality rate is relative to other centers. Here is their trend over time, and here's a caterpillar plot just showing that particular center in relation to other centers across the ELSO community. But maybe this center is more interested in actually their own peer group, which they want to select and create. And so they're able to do that over here. You can see in peer groups, this person has selected Center of Excellence, as well as higher volume centers to compare to. And now you can see this green bar populating across as well. Also, we take advantage of all the depth of data that you enter into the registry, particularly into complications, and build complication reporting platforms as well. And here is just a trend report of major complications, as well as here, which can include things like stroke and intracranial bleeding, leg amputations, things that we really, really want to try to avoid, as well as just general patient and mechanical complications. I want to move though back to COVID to give a little bit perspective on the data. And so I'm not going to go through all of the granular data because, as I've spoken to already, that data is out of date. And because we have this real-time reporting platform, I direct you to just go to the ELSO website and continue to interrogate the data there. And if you have questions, to ask, and we'll hopefully be able to respond to some of those things. But I did want to bring it into perspective with some of the other pieces of information that we have out there. And so obviously the landmark study, the EuroELSO trial published by Dr. Combs and others, and what our COVID-19 patients with ARDS look like in relationship to them. And so obviously this is dominated and entirely viral pneumonia, which is a little bit different than the EuroELSO group, but there's also still complications with bacterial pneumonia as well. In terms of prior to going on ECMO in both the ECMO group of the EuroELSO trial before they were entered into the study, as well as within the COVID experience, you can see that the prone positioning was relatively similar. The use of neuromuscular blockade is maybe a little bit different since the publication of the ROSE study, which showed maybe not as much of a difference with neuromuscular blockade and ARDS, and so there's a slight reduction there. The vasoactive infusion usage is similar, though slightly higher in EuroELSO and inhaled nitric oxide. Though you can see that the severity of hypoxemia was similar in terms of the PF ratio, and as well as obviously in the registry, we don't collect plateau pressures, but the peak inspiratory pressure was 34 relative to 30. Once we get on ECMO, our management looks similar. And then the kind of the bottom line number here in terms of survival are reported slightly differently. In EuroELSO, they measured 60-day outcomes. In the ELSO registry, we measure outcomes to hospital discharge. And in EuroELSO, it was 65% survival. And at current, it's 55%, but those numbers continue to rise. And I'll speak a little bit to some of the questions about why we might expect that to continue to rise. And so a lot of folks do ask us questions about the data. And so some of the common questions that we've received, which I would encourage you to continue to take with a grain of salt, because this is real-time data and it's not analyzed. This is just reporting what's there. But one of the things is, how much longer are survivors supported on ECMO? And so at the time this data was pulled, 567 patients that had survived or died. The actual times of ECMO support were not that much different, around 10 for both. When we look at, hey, what happens to those patients who are supported on ECMO for longer, for more than 14 days? Well, those patients are slightly less than the 55% survival that we have reported now, but they're not substantively different at 48%. And then when we look at what happens when you are ventilated for a long time, well, what I can tell you is that not many people are waiting 14 days to put their patients on ECMO support when they have COVID-19. And so it's really hard out of 42 patients and only 20 of them that have made it to either hospital discharge or death to make any conclusions, but those are the numbers there. And then how much longer are survivors being hospitalized? Well, here it is, there is a difference. And this is why you see some of that lag in our reporting, and why you continue to see as patients as the registry becomes more mature, that the survival continues to rise. Those who survive are in the hospital longer than those who die. And then, children, unfortunately, are becoming a present part of the community with 25 ECMO patients being supported thus far. And because we finally reached a number where we can start to give some statistics, we've built a pediatric filter as well, and that'll be launched on the registry reporting platform this week. But I guess in closing, what I want to say is that the ELSO registry is our centers. The ELSO registry exists to help us all provide better care to those patients who evolve in their critical illness to needing ECMO support. And hopefully it remains responsive to what you need. But the only way we can do that is if you continue to tell us how to improve. And so we continue to urge you to remain engaged and to help us think about how we can do better. And then also, as a final remark, I just want to say that it's also obviously always been built on the shoulders of the giants who set this up, in terms of Dr. Bartlett, John Tomasian, and then all of the previous registry chairs who moved this thing forward to where it is at present. And I hope that 10 years from now, when we have an opportunity to reflect and maybe do something similar, the registry continues to evolve to a place where, like, looking back at it and thinking, wow, we have really come a far way. In order to do that, we need you. That's all. Thank you.
Thanks, Ryan. I appreciate that. And with that, we're going to move to our European colleagues. And I'd like to have the honor to introduce Dr. Roberto Lorusso, who is full professor of cardiac surgery and extracorporeal life support at Maastricht University, and one of the past EuroELSO chairs, as well as his colleague, Jan Bělohlávek, who is an associate professor of medicine and the chief physician at Charles University in Prague in the Czech Republic. And Jan is our current president of EuroELSO. With that, I'll let them begin their talk. Thanks.
Hello, everybody. This is Jan here. Let me take a privilege to introduce myself. Thank you for your introduction. And it's my pleasure, together with Roberto, to introduce our European efforts to monitor ECMO in COVID. Roberto came at the beginning of the large outbreak of the COVID in Europe with this idea to start a kind of survey or study. And it was planned as multi-center from the beginning. And as you know, there has been a different approach to COVID through some of Europe. Some of countries, as our country, started with a pretty hard lockdown since the beginning. And so despite we have completely reorganized the intensive care unit, we have settled the COVID hospitals, COVID units, ICUs, we have purchased a lot of ventilators and actually ECMOs. Probably due to the early lockdown, we haven't seen too much ECMOs here. And basically there has not been more than 10 ECMO patients in our country at all. So, but there is different countries where there have been a lot of ECMOs. So we started at the beginning with the EuroELSO endorsed and approved study that has started exactly on the 15th of March, and the first report was on 21st March with 68 ECMO cases through Southern Europe. And then, as Roberto is going to show, there has been a steep rise in numbers, and we have reached more than 1,000. So, but just with a very brief start, I want to say that thanks to every center that is providing the data. We have reached 163 centers at the moment, and we are trying to continue with this effort and to get more data and information in Europe. And the good news is that a lot of those centers have never reported to ELSO registry, and we're trying to merge our efforts together and provide and offer all those centers to become an ELSO registry centers to have a worldwide initiative to gain data and have a good information on how it's going on with the not only COVID, but all other ECMO patients. So with this, I'm just giving over to Roberto. And Roberto, thanks for all your effort and for idea. You are the engine of this activity, so please introduce us to that. Thank you.
Thank you, Jan. Very kind of you, and thanks ELSO. Thank ELSO for the opportunity to share this data, and actually very preliminary. I just want to make a comment, or a sort of an introductory comment. Why was this started? Because I got a colleague from North Italy calling me for a young patient really doing bad and worse, and asking my opinion. But he said, well, we are not thinking of putting this patient on ECMO based on the very bad experience we heard from the initial outbreak. So in my point of view, that was certainly not the case to be on and on. So we decided with Jan and the other members of the steering committee of EuroELSO to launch this let's say, survey study in Europe, just to see what was going to happen. And also the initiative was meant, and you will see that as the aim of the study, to provide immediately some reports and some update, because in this way the community, the clinical and scientific community, could get some insight about what's going on. So you can find more information about this on the EuroELSO website. You can see this. And everything started, as Jan said, actually at the end of February. There was also discussion with the ELSO Executive Committee, but then we decided to make a European-based study. And thanks to the collaboration of my institute and Maastricht University Medical Center, but particularly with the EuroELSO Steering Committee, and thereafter with a lot of centers, the collaborative centers, making the EuroECMO COVID working group. So what were the aims? Well, just together European nearby Europe centers, so not only Europe, but also Israel, and we got also a center in Russia, we had Turkey and so forth. But so in this area, let's say. And of course, we had wanted to show the actual ECMO use for COVID-19 patients. As I said, particularly comparing the growth or the number of ECMOs, if there was any growth in Europe as compared to the initial ECMO experience in China and elsewhere in the eastern part of the world. But for, as I said, our main task and main objective was to provide weekly report in order to inform the community and all the participants. And I think that was turned out to be one of the most important things, because a lot of people told us that they changed their mind, they changed their opinion about the potential usefulness of ECMO in these patients, just looking at this data every week. And of course, this was not only to show that, but also to collect data for a scientific investigation. And finally, we wanted to have, of course, a scenario about adult and pediatric patients. So regarding the adults, we started, as I said, at the end of February to put up together a very simple data sheet to get some basic information. And we proposed that to some centers on March 15. And you can see here the numbers at the beginning were quite limited, only 51 centers, but still quite, I think, a high number of centers participating. And that was March 15. So now this is has been just released this morning. You can see that we reached 166 centers. So I think we are really proud. And I think of course, the reputation of ELSO, EuroELSO, but particularly the willingness of non-ELSO centers to collaborate was so great. I think this really made us achieving an outstanding results in terms of collaboration. And you can see here regarding the number of ECMO used in the various countries. You can see that in France, there was the vast majority, but you can clearly see that the western part of Europe was, as you know, was very largely hit by the COVID-19. You can see that Italy, Spain, UK, Germany were really had quite a high number, but not as high as France. But what about the number of centers? I told you, look, you can see every week the growing number of centers collaborating with our project. So we are really proud of what has been achieved, but we are really thankful for the centers which decided to join our adventure and giving the data and giving the information. And here you can see also how the numbers change along the study period. And you can see that now we have almost 1,300 patients. And of course, again, we have now preliminary data, which I'm going to show you. But I think, again, these data provided every week gave a little bit of feedback of what was going on. Although, again, as I repeat, were preliminary data, so it was really rough scientific communication, but still very important in my point of view. And you can see here the situation as far as today is concerned. So still almost 200 patients still ongoing with ECMO. So this means that quite a substantial number of patients are still supported. So you can imagine that we cannot give any conclusive data or information based on these situations still ongoing. But again, you can clearly see that ongoing cases are rapidly going down. And the mortality, this is very important. You can see in these slides, the mortality of the number of patients died on ECMO and the very few, but still a relevant number, I would say, dying after ECMO weaning, you can see here. So after all, what we have now as a preliminary data, we have the survivors, but still, as I said, preliminary because still patients are hospitalized, maybe someone in the ICU or someone still in the hospital. The mortality, the survival rate is 48%. The mortality is around 37%. You can see almost 90% on ECMO and almost 10% after ECMO. And the ongoing ECMO represents still around the 15% of the total patient population. So again, this will, I think we'll still have a couple of months, maybe 1 month for sure, but I think within 2 months, we will have most likely the entire information about patient surviving at hospital discharge, as ELSO did in the addendum, or patient dying on ECMO or just after ECMO weaning. What is interesting, the type of ECMO, you can see almost 90% of patients were submitted to veno-venous ECMO, and around 10% of VA or other hybrid configuration. And this is something very interesting that we are going to look more carefully once the data will be available. And again, patient profile, another interesting, of course, collection of data is about the mean age. You can see a little bit higher than 52 years. And you can also clearly see, and this is another interesting information, that in some situations, some instances and circumstances, patients older than 70 were supported by ECMO, in contrast to what everybody believes that the contraindication regarding age was 70. And again, what we know about the gender difference is confirmed also in the ECMO population. You can see that almost 80% of the patients are male and only 20% female. So regarding pediatrics, that was another initiative. And you can see again a lot of centers participating this survey study from EuroELSO. But fortunately, the number of cases regarding pediatric patients has been very limited. You can see only 7 cases up to June the 1st as the data of data collection. And you can see for the moment we have almost 60% of patients surviving and 40% non-surviving in the pediatric population. So what about, I would say, the conclusion of this experience, and I would call it adventure. Really, it was a really adventure, a scientific adventure. I think that this was certainly an important initiative in the COVID-19 patient, thanks to EuroELSO and collaborative centers. I think that it showed a really large participation. Really, I think unexpected. We couldn't really imagine to have so many centers at the beginning of this adventure. I think this was really important because it provided, as ELSO did with the online information, to provide constant and timely updating. This really, I would say, give a little contribution to the number of ECMO used. And I think that also made the change in the perception of the scientific and clinical community regarding the use of ECMO in contrast to initial skepticism. And I think that, as I showed you, we still have preliminary data, not conclusive, but already we had some relevant insights for this survey. So I would like first to thank all the collaborative centers, of course, the steering committee of EuroELSO, which made this possible. And let me thank my PhD fellows who really have been so important, the data collection, center contact, and also the organization of my institute. But for whatever information you want to have additionally to this, you can go to the EuroELSO website. You can see here the link. And after all, what I can say, I think that we have absolutely to join ELSO because these initiatives are so important and prove to be also instrumental for a better patient management in this respect. Thank you very much.
We're moving on to the next section now. And Elizabeth, if you could clear the screen for us. Wasn't that a fantastic presentation? Amazing collection of data in a very short time, which, as Roberto said, has been influential in everyone realizing, well, ECMO may do some good for these patients. The last session of this webinar relates to a very unique data collection system headed by John Fraser, and he will tell you about it. John is, first of all, the chair of Asia Pacific ELSO, an investigator, a researcher, an adult intensivist from Queensland, Australia. And he perceived early on, when this virus was just beginning in China, that the Asia Pacific area could be inundated and organized this remarkable system that he will tell you about. Heidi Dalton, of course, has been a stalwart of ELSO from the beginning, past chair of ELSO, and currently a pediatric intensivist, although she's definitely in the adult world as well, heading up several ECMO programs, but the main one at the moment is in Virginia. So John and Heidi, thank you for joining us. It's up to you.
Lovely. Thanks, Bob. I'll ask Heidi to share the screen. As any sensible man knows, Heidi's normally in charge of pretty much everything, and we're not going to change things here. So it's wonderful to speak after people that I've respected as leaders and people that I've learned from as a junior, obviously both Bob and particularly Roberto Lorusso. Look, we're here by mistake. Let's be honest, as chair of the Asia Pacific, I was asked when I took over, could we do some research for a relatively new chapter? And we decided we were going to look at some flu if it broke up across Asia Pacific. So in November, with some of our colleagues in the Wellcome Trust, we were interested in looking at the gene changes, why some people got flu and needed 2 paracetamol and some people ended up on ECMO. So by mid-January, we saw a blip, and we've got a large research group in Brisbane with 88 international staff. You're all welcome. And my stalwarts, and I get a lot of credit here that I don't deserve, but Gianluigi Bassi and Jackie Suen, I said, look, we should start looking at this thing. Maybe this is a flu. How wrong was I? And we had the protocol written over the weekend by about January the 16th, 17th. Our great group of Asia Pacific ELSO had it translated into 3 or 4 different languages by about January 25th. But even by this stage, we realized that this was going to be bigger than just ECMO. So whilst this was our interest and it came from AP ELSO, we said, look, I think we need to understand more than just ELSO. What's the denominator? what are the other things that are contributing to people going on ELSO? When are they failing ventilation? When are they going into cardiogenic shock? Let's increase the data capture substantially. And that's what we did. And what you've got left with now, and this is the starting and probably the ending slide, is 370 centres across 51 countries coming together to gather all ICU data, not just ECMO, but ventilation, renal function, coagulation, neurological function. Next slide, thanks. So it's really about, I think it's 370 centres now, and it's all the ICU data, of which ECMO may be part in many of them, but we're also looking at low middle income countries, and these countries are getting absolutely smashed by this disease and are just as important as the wealthy countries that do have ECMO. So we are looking at these too. So we're looking at everything to do with anyone that comes into intensive care with COVID-19, thanks. So this is who we have, 50, I think 51 today. I think we got Libya. And as of this morning, 1,021 enrolled patients. On day one, it's a lot of data, and we're going to talk about how we've made this easier. We collect about 350 data points in day one and about 160 on every day thereafter. We've got 90 centres that are actually getting data in. As you can imagine, the amount of legal and the amount of regulatory systems when you're dealing with 50 or 51 countries has been truly phenomenal, and I never want to do it again. The exponential growth curve of centres contributing data is there on the right-hand side. The countries that are actually contributing data at the moment are shown in this graph, but I can tell you there's a lot more countries that are actually assigned and ready to rock as soon as they get their IRB. We've worked alongside ESARIC and Sprint SARI to try and get these as well. Thanks. Next slide, Heidi. Thank you. If you look, this is really our history. So we were very fortunate to have people like ELSO that have been up and running for 30 years. We've been up and running for about 100 days. So we started this really on about January 21st, and within 5 months, we're over 1,000 patients enrolled and got a consortium of over 51 countries. So that gives you the timeline of how rapidly we've created this alongside the WHO and the CDC with Sprint SARI and ESARIC. We will make mistakes, but we saw a need, and a little bit like one of my idols, Roberto Lorusso, said, lots of people were phoning us saying across the Asia Pacific, somehow because I'm chair, I'm meant to be cleverer than them, and I'm not. And they said, what do we do with these patients? And I had no answer. We had never seen this disease. We hadn't seen the way these lungs work. We didn't understand why they're getting delirium. We didn't understand the cardiovascular problem. So we had no data. We had no book or textbook or recipe to look at. And we said, well, we don't know. But our thinking was this. As this grew and grew and grew, we thought there will be 10, 20, 50, 100,000 human jigsaw puzzle pieces across the world. And if they are all separate, we won't be able to make a picture. But if we can bring these jigsaw puzzle pieces together, regardless of country and creed, we can hopefully make a picture that we can start to understand how to ventilate, how to dialyze, when to ventilate, when to put on ECMO. And that's roughly our rationale. Thank you. Next slide. So we brought together the best and the brightest, because that certainly doesn't describe us. And these are your committee, or the steering committee. We've gone pretty globally. Got people from rich countries, from poor countries, from whites to yellows to blacks, from men to women, and got all people that we thought were very, very good workers into the team. We've also added to these Sprint SARI and the ESARIC networks as well, and there's still some space otherwise. Yep. We have a weekly conference call. We've actually had to double it. So as you see in the left and right of the screen, with the West Coast of America really contributing a lot with Harvard's and Hopkins and all the big names. So we have between 200 to 230 centres joining between the Thursday evening call and the Friday. Everyone is welcome. Please don't feel you need an invite. We'll send you the Zoom addresses on the bottom of the screen. And what we do is we explain where we're at with the data collection. We hear from different areas what we're doing. Different countries get to represent what's going on. So last week, for example, we had New York with Columbia Presbyterian and Dan Brody, followed by Wuhan. So a great juxtaposition of what was going on. Then the subsequent week, we had Vietnam with 1 patient on ECMO and no deaths. Sadly, on to Brazil with hundreds of thousands of patients and thousands of deaths. And as we present what we're doing, we always find better ideas from our collaborators. And I make the point frequently of saying, this isn't our consortium, this is theirs. We're just really trying to run it for them, and frequently don't do that particularly well either. Yep, next slide. We think about this each week. This came to us when we'd heard one of the presenters actually was presenting the day after her sister had died, and yet she still turned up. She still presented her data because she knew how important it was. So as this disease goes through different countries, and in Australia, realistically, we have a very little burden, we are trying to remember those people that have lost loved ones, family, friends, colleagues. And as Mandela said, it always seems impossible. It's done. Trust me, when you're talking to 16 different lawyers across 16 different countries, never mind states, it really does seem impossible. But I think the will that's there, and it's born through the ECMO community and through the ELSO network that Bob and his people have created, and the people in Europe with Roberto and our colleagues like Valeria have done. There really is a groundswell of people wanting to do better. So we have the main database, and I'm going to ask Heidi to talk about this. And what's happening subsequent to this is different people are coming out with great ideas, and rather than do them separately in different silos, we're joining them together. So with the neurological effects, Chiara from Genoa is joining up with Sung Min in Hopkins and looking at neurological effects, and bit by bit Canada and other centres are joining. We're looking at the cardiac effects. There's a separate subgroup that Giles Peake will run on a multitude of ECMO studies, and Eddie Fan is running realistically one of the key studies, the propensity analysis, when to ventilate and when to switch over. Heidi, who we're going to hear from next, is going to look at the sort of coagulation and thrombosis, and again, this will tie into neurology. We have ethics studies looking at when do people decide who gets ECMO or a ventilation or not. Last week we heard from the Western Cape in South Africa, where they're not even offering ventilation. They just have either oxygen, high flow, or nothing else. From the Lung Safe study, John Laffey in Ireland is running acute kidney injury, and then the data collection tool, which I think is really, really interesting. But probably the most important study, without being rude, is the long-term follow-up. This disease has not lasted longer than 5 months. We don't know what happens at 6 or 7 or 8 months. We don't know if you die at a year. We have no idea. So the long-term follow-up is not just important medically, but is important from a societal point of view. Who goes back to work? Who can earn taxes? Who needs long-term care? We don't know. And this is where it's really important. And these groups are all open to everyone in this call, or even better, different ideas that we've not thought of. Thank you. Next slide. So the issue here is we're taking a bucket load of data. So, you know, as a Scottish person, we like lots of data and we like to do it for free. So I initially thought of getting Google Glasses and basically being able to look at data and write it in, because I've always hated data entry. It turns out Google Glasses don't exist anymore. So I went to Amazon Web Service and said, is there a way that you can take your device, your Alexa, and teach it? Can we educate your Alexa to become a COVID consortium toolkit? Because our teams are under stressed. The information's there, but we're not getting it together. We're not building this jigsaw puzzle. And we can wait for a vaccine and we can wait for treatments, but the best thing just now is technology. The data is there. As Hwachin Cho's paper showed this morning, this is really the first time that we've had a pandemic or an epidemic with real significant artificial intelligence and being able to use that. So we said to Amazon Web Service, help us here, and obviously being Scottish, do it for nothing and create us something that won't just change the way that we do this here with ECMO and with the COVID-19, but will change the way that we collect data for every clinical study thereafter. Yep, next slide, thanks. And they've done a fantastic job. They've worked with us, they've co-developed us this. We've changed Alexa to the name Bruce because it's been born in Australia. And it's looking at it, making it more efficient, making it so whether you're a doctor or a nurse and you're looking after sick people and you've been up for 12 or 14 hours with an N95 mask, you can actually collect the data, not in 4 hours, but maybe in 20 minutes. It learns from us, we're teaching it, and we're working with Amazon on a daily basis. And then the data is safe and secure. It's transported across Amazon Web Services, as I've found out are the CIA data, and so is the WHO. So in terms of protection of data, we're all cushy there. Yep, next slide, thanks. And when this data comes in, what do we do with it? We could just display it and use brilliant statistics, and we've got the Australian President of Stats on there. But surely if we get enough data, we can do something smarter. So the UQ team with Sam Hinton and Sally Shrapnel and various others have created an artificial intelligence network where the more data we get in, and this is my pitch to you, the more data you give to us, the more we can educate the machine learning. And when that happens, the more we can give decision support. So they've created, and this dashboard is live and you can look at it there. They've created a dashboard. So we're interested in publishing papers, that's fine. But what we want is a dashboard in the hands of every man, woman and child in an intensive care unit. So that when you're sitting looking at someone sick and you don't know how to ventilate, or you don't know how to dialyze, you don't know when to put them on ECMO, the data will be there. And when we get 5 and 10,000 patients, and we will get these numbers, we can actually say this 55-year-old man with a PAFI ratio of 120 and a creatinine of 260, if you ventilate now, this is what will happen. If you put on dialysis now, this is what is likely to happen. So individual decision support, not telling you what to do. And then that dashboard moves with the ICU project, where IBM has given us 10 staff full-time to supercharge this dashboard. Yep, next slide. So that they will create this dashboard, and it will give you, if you look on the left-hand side, it's scenario 1, so you can put in a whole pile of specifics about your patient, and it can guide you, your comorbidities, the symptoms, and guide you about what you can do down at the bottom here as to what will happen and what the likely outcome will be with these. And this again has been co-developed with clinicians from 18 countries with the people in IBM that know exactly what they're doing, but it's giving us a dashboard, and that's the key. This should be in rich or poor countries in your pocket and be able to help you make decisions on this difficult disease. And that will be live in about 2 weeks' time. And this is what you're kind of going to get. You're going to get, and we've got data for over, I think, 1,200 patients, I think, as of today. And these kind of data will come out and it will guide you. We can show this later on. Next slide, thanks. Yep, we'll just keep going on through that. Again, we are interested in pediatrics. Again, Huachin is leading this, got a lovely new graphic with 2 babies crawling around. I think they've got about 200 pediatric centres, including Libya and Cambodia, etc. So please answer this pediatric ICU and ECMO survey. Is very, very wide reaching. From the cardiac point of view, these are some of the ideas. I'm not going to go through them too long, but cardiac dysfunction is significant, and we're looking at different aspects, both short-term in the intensive care and the long-term. This is the ECMO card study. Giles is running it, and Eddie will run one of the main papers there, but there's a lot of different ideas there. Happy to take other ideas if you got them. These are some of the research agenda. Who should get them? Phenotype, and again, our first paper is going into JAMA, courtesy of Gianluigi and Heidi and Jackie, etc. today. What lung phenotypes are the different lung phenotypes? How do we manage ventilation? What about health system organisation? What about transport? Lots and lots of great ideas. Looking at the incidence of ECMO and brain injury on COVID-19, we're seeing a lot of strokes, whether they're on or off ECMO, but we need large volume ECMO centres to give us the data, and the SLAC database is there too. Yep. We're also working in resource poor areas, and in fact I was just chatting to the United Nations group and the Wellcome Trust just before this call. Great colleagues in Kenya, South Africa, Zimbabwe, Vietnam, India and Cambodia. There's some fantastic work out there. These guys and girls are getting absolutely smashed with the disease. It's now a responsibility to be able to help them as much as we possibly can from the ELSO family. Yep. And this, I'm going to pass over to Heidi after this slide. This is a fantastic, interesting one. It's talking about when do people get ECMO or not? What do you do to decide you got 1 ECMO machine and 2 patients? So these are some of the ideas that we're trying to create, and it's your consortium, and I'll pass this over to Heidi.
Thanks, John. So that is a very brief overview of what the consortium consists of. And if you're not a member, we certainly would invite you to join us. The idea that we have global data in real time, I think will be very important, not only now, but as we move forward in this pandemic to help guide patient therapy and maybe develop some best practices. The other thing I would mention is that really this has turned out to be a great networking effort. There are a lot of these studies that are being proposed and run by junior faculty. And this is a good way to get involved with people throughout the world, actually, not just in your own center, but for networking, it's also turning out to be a really great resource. One of the things that we hope to do is educate the world on what we're finding. And so I'm going to run through very quickly a few slides on our first paper, which is being submitted probably this week. And this is looking at how we're ventilating patients. So here's the flow chart of patients that we evaluated. And basically, this paper was going to look at the use of respiratory mechanics and compliance in these particular patients. And these slides are, none of this stuff is published yet, so they probably won't be in your slide pack. But just real quickly to show you that there has been a male preponderance, just like other people have said. You can see that we are able to look at symptoms, BMI, duration of ICU stay, all these different things with the data that we have available. The type of vent support that patients are getting prior to ECMO or prior to mechanical ventilation, this is not an ECMO project, is shown here. And you can see there's a lot of variability throughout the world in terms of how we manage patients even before they're intubated. And then once they are intubated, you can see that the majority of patients are maintained in control modes, either pressure control or volume control. And if you look at the adjunct therapies that are being applied to these patients in the first 7 days of mechanical ventilation, you can see kind of surprisingly, I think, that many of them are paralyzed for the first 7 days. The use of prone positioning actually is relatively low. And is that because we don't have enough people to flip them over, or because people have regional differences and don't believe in prone positioning or whatever? We'll be able to tease that out over time. But you can see the use of nitric oxide and ECMO, at least in these first patients that we're evaluating, are relatively low. You can also see here we looked at high and low compliance, and we based that on a break rate of 40 cc's per centimeter of water. And you can see that the majority of patients actually are in a more normal compliance range when they are intubated. But you can see also that if you look at the PF ratios that go along with this, you can see there are quite a few patients that had severe PF ratios less than 100 in these particular groups. And you can also see that there is a difference, maybe not statistical, but a difference in terms of male and female compliance in these patients as well. Another interesting finding is that even though respiratory compliance is relatively low in a lot of patients, no one seems to be dropping the PEEP a lot. The average PEEP in all these patients over time was about 12, which would seem to be quite high for somebody that has really compliant lungs. You can also see that tidal volumes are maintained sort of in a safe range of 6 to 7 cc's per kilo over the compliance range. And just real quickly in summary then, the low compliance patients did have more prone positioning recruitment maneuvers. They were on the ventilator longer, but actually, unlike some of the papers that you've seen already, in terms of outcomes, whether or not you had high or low compliance when you entered the intubation phase really didn't seem to affect outcome yet. And again, this relatively high PEEP in all patients is very interesting. You know, there is some suggestion that this is detrimental to the lung because it increased dead space and shunt and may adversely affect gas exchange. But this is some of the type of data that we're going to be able to drill down to and help supply the world, hopefully, with some updates on best practice as we move forward and try and do the best we can for our patients. This is how you can learn more. And if you go to these websites, all the IRB forms, protocols, etc., are available. And with that, I'll close and thank you on behalf of John and myself for listening.
Thank you so much to John and Heidi. Wonderful, innovative information and technology coming our way. So thank you so much for sharing. I know we're kind of dwindling to the end of our webinar time today. So I do have just a couple questions. The first one was answered live, so I just wanted to share. There was a question regarding how many registered ELSO European centers prior to COVID-19 and how many are new centers set date. So Christine said our CEO of ELSO was able to get on and with Peter Rikis's help pull that there's currently 136 European ELSO centers, including 18 new centers that have registered since the COVID pandemic has began. So we have seen some new traffic to new centers and joining our efforts. The other question that came up, and this will be towards Ryan and Matt, some clarity on. The question is, as a developing ECMO center currently working on becoming an ELSO member, are we able to enter data on our COVID-19 patients placed on ECMO prior to our official membership date? So Ryan or Matt, trying to figure out for a center.
Hi, thanks so much. So the way that we enter data into the ELSO registry does require that you have a data entry permission. And so there's not a way to enter data without being a member of the ELSO registry, but we certainly can do everything we can to help you achieve that. And we have lots of folks available to help you to do that. And right now, of course, there's no cost to join. So we want to remove all the barriers that we can to help to provide you the opportunity to enter that data as soon as possible.
And Ryan, you mentioned that there is a free membership right now. So how would one go about doing that if somebody's listening and not a current member? How can somebody get on and take advantage of that?
That's a great question, Elizabeth. I actually don't have the opportunity to do that, but maybe Christine or Peter, if they're on the call, could speak to that as well.
So the information is available at elso.org, and feel free to go and look there. The other thing you can do is email membership@elso.org, and we can provide you with all the information that you need to get signed up and become a member of ELSO.
Yeah, and we got confirmation online here for Christine that shared that it is at membership@elso.org. It's all you have to email, and you will receive a code via email, which will waive that 1 year of membership fees. And that'll help give your user login information at that time. All right. I think that concludes all of our questions that have come in, lots of registry ones in there and volumes regarding how many new centers that we've seen. So I just wanted to take this moment to thank you all again. Thank you to our speakers, thank you to our moderators, as well as to Belia Antonini and Tammy Frederick, who is behind the scenes kind of helping navigate some of the questions that came across. A few reminders before we log off. So watch our social media pages as well as our website, elso.org, for updates on future webinars. Also for information regarding ELSO's 31st annual meeting, which will be virtual this year in September in that same time frame. So I know that that agenda is nearly shored up and is looking to be a great virtual meeting for everyone. So please watch for information. I also wanted to mention a save the date for EuroELSO's virtual day, which is Thursday, June 25th. So that's coming up. You can visit EuroELSO-congress.com for more information related to their virtual day. So thank you all again for joining and hope you have a wonderful day.